non-inferiority margin, meaning that there is this risk of tofacitinib in terms of developing MACE, major adverse cardiovascular events, and also malignancy. Now, this leads to the regulatory decisions after this oral surveillance, whereas the FDA actually issued box warning and also for the European EMA as well. And in this warning is that we have to be a bit careful, especially in terms of patients who are on JAK inhibitors, because of the risk of mortality, including cardiovascular death, major adverse cardiovascular events, and also malignancy, and also in terms of thrombosis. And this is similar in terms of the European, the EMA. So one of the box warnings that when we start to consider using the use of JAK inhibitors, and this is not only applied to tofacitinib, but the whole other JAK inhibitors as well as the same class. So especially we have to think about patients at high risk in terms of age over 50 years, smoker, history of myocardial infarction before, and those high risk of VTE and even cancer. Now, this leads us to what we do in clinical practice, because from the oral surveillance, it's patients who are rheumatoid arthritis 50 years above with cardiovascular risk. But in our practice, obviously, we see other patients as well. We see these patients, we see smokers, we see elderly patients with rheumatoid arthritis, we see patients who have cardiac problems. Sometimes they don't even tell us when we see them in the clinic, and patients with a history of malignancy and also risk of thrombosis. And these are the patients that we have to be aware of, especially with the use of JAK inhibitors. I'm not saying that they are negative, but there are also significant benefits of using JAK inhibitors compared to biologics. And when we say in terms of rheumatoid arthritis management, now, and based on the oral surveillance, so we think that maybe there might be a risk in terms of using JAK inhibitors with patients with cardiovascular risk and malignancy. But if we look at the population in our rheumatoid arthritis itself, and this study actually showed that hypertension is actually present in a lot of our patients, and it is tend to be underdiagnosed in the younger patients. So 39% of patients are actually undiagnosed with hypertension. About 1 in 5 patients were optimally controlled, which is less than optimal. And patients with uncontrolled hypertension was actually older and in the obese patients. And if you can see from this chart, you can see here that patients in terms of having uncontrolled hypertension and undiagnosed hypertension increases as the BMI of the patients increase. And you can see here in terms of the visibility, in terms of the percentage of patients with RA, more patients with a BMI of higher, which is here more than 28, in terms of having uncontrolled hypertension and also undiagnosed hypertension. And it's not just the real world evidence in terms of hypertension and also risk factors. If we look at the randomized controlled trials for these for these JAK inhibitors medication, and the most common cardiovascular risk in these randomized controlled trials were hypertension and hypercholesterolemia. We have here tofacitinib, baricitinib, and upadacitinib. If we look in terms of the rates of hypertension being present in both tofacitinib and baricitinib is about 30 to 35%. Hypercholesterolemia, almost half of patients in the randomized control trial for baricitinib is present, and also about 1 in 5 patients will have elevated LDL in randomized control trials involving upadacitinib. So it's not just in the real world, but it's also when they do these randomized clinical trials in these JAK inhibitors, they are present as well. Now, this leads to the understanding that we have also evidence in the real world studies that JAK inhibitors may increase LDL levels. Now, this is a network meta-analysis looking at the LDLs in patients on various different JAK inhibitors. I know it looks a bit busy. In terms of the summary, the LDL levels actually increased by 11.3 milligrams per deciliter. Now, there is a bit off in terms of variability in the studies. If you see the level here is about 88% of the I-squared. But generally, there is also a risk from our own clinical observation that the LDL can also be increased in patients with JAK inhibitors. And there is also a study, I would say closer to our home, patients from Korea, and they look at patients who are on JAK inhibitors, so apart from the HDL, in terms of non-HDL change, there was also a significant change in terms of the non-HDL cholesterol when patients are on JAK inhibitors. And when we look back at the oral surveillance study, now, this is another study which was published recently as well, looking at the oral surveillance, looking at the post-hoc analysis for this oral surveillance in terms of the use of statins in that study population. Now, just as a reminder, again, the oral surveillance in terms of the patient population, they had definite RA over the age of 50 and one additional risk factor. And this post-hoc analysis actually looked at the statin usage in terms of the baseline CV risk profile. They look at the lipid levels, and also they look at the statin use and incidence of major adverse cardiovascular events for patients on tofacitinib. And from the results, it shows that in the oral surveillance post-hoc analysis, LDL was actually increased from baseline with tofacitinib, then anti-TNF, and you can see the chart on the left. So patients who had not received any statins, but are on tofacitinib, you can see here the blue and the green line, they increase significantly higher compared to patients on anti-TNF. Whereas patients who have been on statin before they start the clinical trial, the levels were fairly similar. So this sort of brings in terms of the issue regarding the risk of cardiovascular events from the oral surveillance. And what's more interesting from the oral surveillance analysis is that the use of statins in these patients were not really optimized. So if you can look here, about over half of patients with RA who have a history of atherosclerotic cardiovascular disease, only 53% of them receive statin at baseline. And if you think about it, patients with ASCVD, they are higher risk. And most of the time we would, in our clinical practice, recommend at least to be on a statin. But in terms of the oral surveillance, this was not actually achieved. And in the oral surveillance as well, in patients who have ASCVD and on tofacitinib, the occurrence of major adverse cardiovascular events was also increased significantly in patients if they didn't not receive statin. You can see here on the in the red box above, the risk of whether it's tofacitinib 5 milligrams BD, 10 milligrams BD, or combined doses have significant higher risk compared to patients who were already on statin. So this makes a bit significant difference in terms that how these patients were actually included in the trial. And it comes in terms how we think about how tofacitinib and biologics work. How does it actually affect patients who have risk of major cardiovascular event? And if we look over here, obviously we start to understand that based on the FDA black spot warning, we have to be careful in terms of patients on tofacitinib or even JAK inhibitors in general. And the thinking here is that the probability of patients who will develop major adverse cardiovascular events, if they are not on any medications, obviously the risk will be higher. But if they are on tofacitinib, the risk will still be there. But here we can see that maybe the theory is that patients on biologics, especially anti-TNF, might have a lower risk than patients on JAK inhibitors. And if we wonder why, there are several reasons why this can happen. Obviously, in terms of rheumatoid arthritis, that inflammation actually drives the risk of developing cardiovascular risk. The traditional CV risk factors is also there. So whether they are smoking, etc., that's something to be considered. Cardiovascular risk factors in terms of pharmacotherapy. And one of the things in terms of the effect that leads to cardiovascular risk in these patients is the use of these medications, JAK inhibitors on anti-TNF. And why would I like to mention this? Because when patients who are on anti-TNF per se rather than JAK inhibitors, there have been evidence showing that TNF inhibitors or biologics have actually the potential to reduce the cardiovascular risk in patients with rheumatoid arthritis. So we look at anti-TNF per se, the risk of not having any biologics versus patients on biologics is significantly different. And patients who are on biologics, you can see here in the black line, the risk is significantly lower compared to patients who are not receiving any biologics at all. And similarly, this is for the major adverse cardiovascular event. If we look at the risk of developing ischemic CV events, the trend is also similar. And another thing in terms of biologics, the benefit, I wouldn't say benefit, but what happens in terms of the disease activity when patients who are on biologics is that inflammation will be reduced when they are on treatment. And this also tends to reduce the cardiovascular risk. And we look patients who, in terms of patients who have been on biologics compared to no biologics, the risk is lower in terms of major adverse cardiovascular events and also ischemic CV events. So this tends to, in terms of change our perspective of how we actually use advanced therapies in rheumatoid arthritis. And this is the latest rheumatoid arthritis treatment recommendations, just published, I think, about a few weeks ago, and you can probably look your eyes into the name. I think Professor Babur Salim has really helped in terms of the development of this rheumatoid arthritis treatment recommendations for APLA in 2026. And one of the key statements in terms of APLA treatment recommendations in RA is that a biologic or targeted synthetic therapy DMARD should be considered promptly without delay in patients who have poor prognostic factors or inadequate response to conventional synthetic DMARDs, especially those who cannot tolerate conventional synthetic DMARDs. The other important statements with regards to the use of targeted synthetic DMARDs or JAK inhibitors is that they are, although they are most effective combined with conventional synthetic DMARDs, but the use of the JAK inhibitors or targeted synthetic DMARDs are beneficial, especially those who are on monotherapy. And similar with the rheumatoid arthritis treatment recommendations from EULAR, this was also published, I think, about last year. This has also its own treatment recommendations, similarly to the APLA 2026. Now, if we remember in the previous EULAR recommendations from 2022, they did mention about the use of biologic therapy to be included, especially in terms of looking at the poor prognostic factors here on the left, if they are present. Now, in the latest update for the EULAR 2025, they've removed this poor prognostic factor. And instead of going through these two routes, we can actually start a biologic DMARD or a JAK inhibitor, depending on the risk assessment of the patient. So there's no need to consider a biologic first. You can either consider either one of these in terms of patients who do not respond to conventional synthetic DMARDs like methotrexate, leflunomide, or sulfasalazine. And in summary, these treatment recommendations in rheumatoid arthritis have reiterate that there is a greater role for JAK inhibitors for our current practice, because JAK inhibitors are now positioned alongside with interleukin-6 inhibitors, especially those who are on monotherapy or who cannot tolerate conventional synthetic DMARDs. The other highlight in terms of these treatment recommendations is that treatment should be maintained. In clinic, we always get questions from patients, right? When can I stop my biologic? When can I stop my JAK inhibitor? And it's a question we always try to find answers, but at the moment, from these two recommendations, that treatment should be maintained. The recommendations have given advice that although discontinuation is not recommended, but you can actually reduce or dose tapering the dose based on the patient profile, but obviously withdrawal is not encouraged. And obviously the final change in terms of treatment recommendations that we recently have is that to escalate the use of biologics or targeted synthetic DMARDs early when we see these patients, rather than leaving it late, and obviously try to optimize therapy in terms of earlier to improve the long-term outcomes. Now, EULAR has also provided other recommendations, especially in terms of CV risk management in patients with rheumatoid arthritis and inflammatory joint disorders. And from their recommendations specifically for cardiovascular risks, you can see that the rheumatoid arthritis should be controlled, because when we control the disease and the inflammation, this can indirectly lower the risk of cardiovascular disease. So inflammation control is actually quite important when we see patients with RA. Sorry. And the other point is that from this recommendation for CV risk is that all rheumatoid arthritis patients should have a CV risk assessment at least once every 5 years. I'm not particularly sure why 5 years. Maybe you can do more frequent if you like. But obviously, when we see these patients in the clinic, we always ask them in terms of any new onset or any new cardiovascular events that they have, and we have to tailor in terms of management, how we treat around these patients. But this is one of the things that recommended that we should screen these patients every 5 years. Another important point I would like to highlight here is that although we know that patients are at risk, but whenever we do a prediction model in terms of how high the risk is, patients with RA, the risk predictor should be multiplied by 1.5. So when we'll calculate some of these predictors of how high the risk of developing cardiovascular risk factor, rheumatoid arthritis has a slightly higher risk in terms of the local normal healthy population. And finally, in terms of the steroid use, we try to keep it as a minimum. There also we know that there are complications in the use of steroids, but obviously steroids itself can also increase the risk of cardiovascular risk factors as well. And at home in Malaysia, we have various different guidelines to manage our cardiovascular risk patients. This is the Framingham Risk Score. I'm sure you have all seen this before, and I think our guideline is a bit outdated. It's almost 9 years from the latest clinical practice guidelines in terms for Malaysia. But if you see here that the guidelines actually takes into account age of the patient, HDL, total cholesterol, blood pressure, whether they are smoking, and also whether they have diabetes as well. But nowadays, what we tend to learn is that rather than just looking at the LDL, there are now newer methods in terms of the apolipoA. You may have heard this before because it actually, one of the measurements in terms of assessing the apolipoprotein A is that it has a better in terms of detecting the prognosis even earlier. I think it's available in Pakistan. We have it in Malaysia as well. And I think the use of it might be able to help assessing our patients in terms of cardiovascular risk even earlier. And when we look at generally in terms of the use of JAK inhibitors, rheumatoid arthritis, in terms of efficacy, it works very well. It brings the joint swelling inflammation very fast. We've seen patients having resolved joint swelling within 2 weeks, which is amazing in terms of its efficacy. It also lasts longer. So there is study on upadacitinib saying that the drug retention is even longer than biologics. Safety, we have to consider. Obviously, we have to choose our patients. It's not a black and white contraindication to start patients who have risk on a JAK inhibitor, but it's something that we need to assess. And finally, in terms of patient preference, some patients, they don't like injections. In Malaysia, they say needles. They might be scared of needles. When they travel, they don't want to bring all the injections with them with the cooler box. So they prefer tablets. So we have to bear in mind and take into aspect as well in terms of preferences using an oral medication. And finally, take-home message. So JAK inhibitors, it has been an important component in how we manage rheumatoid arthritis. But when we manage rheumatoid arthritis, we should also be aware that there are high risk to develop cardiovascular disease in RA patients compared to the general population. And now we have various international guidelines to help us, especially with the study of oral surveillance. So these guidelines would recommend us how we use JAK inhibitors who have actually inadequate response to conventional DMARDs. And finally, I think patient selection is actually very important. This is the key because the benefits of JAK inhibitor, we should balance in terms of the risks, and especially those who have cardiovascular events, malignancy, thromboembolism, and also serious infections. And with that, thank you very much.
Thank you so much, Dr. Faris, for completing your presentation exactly in 20 minutes.